A novel approach to achieving target blood glucose levels in patients who are already on insulin is to add a weekly GLP-1 agonist. They improve glycemic control, induce weight loss, and often reduce the total daily insulin requirements. This class of medication mimics the natural incretin hormone GLP-1. The modes of action include reducing inappropriate glucagon secretion, increasing glucose-dependent insulin secretion, slowing gastric emptying, and suppressing appetite. Currently, these are the 4 GLP-1 agonists available in Australia indicated for diabetes. They include semaglutide, dulaglutide, tirzepatide, and liraglutide. Because PBS guidelines are fast changing, please consult the latest update on the PBS website to know which medication combinations are subsidized. The 2021 Diabetes Association Standard of Care notes that the combination of GLP-1 agonist with basal insulin has potent glucose-lowering action and less weight gain and hypoglycemia compared to the intense insulin therapy. Some points to consider when starting a GLP-1 agonist as an addition to insulin therapy are: evaluate the current glycemic profile with 1 to 2 weeks of blood glucose recordings or a CGM. Review the precautions such as active bowel disease or pancreatitis. Explain the expected side effects such as nausea, change in appetite, and rarely vomiting or diarrhea. Currently, there are no clear guidelines describing how to adjust insulin doses when initiating GLP-1 agonists. Landmark trials have shown GLP-1 agonists to reduce insulin requirements by about 10 to 20% depending on the baseline HbA1c levels. The tighter the baseline HbA1c, the higher the percentage drop in insulin doses. Western Sydney Diabetes team has developed a quick guide on how to titrate insulin doses when initiating GLP-1 agonist. At the first consultation, commence the weekly GLP-1 agonist at the lowest dose. Cease the DPP-4 inhibitor and consider ceasing sulfonylurea. Other glucose-lowering medications can be continued. If the patient is already having hypos, reduce their total daily insulin doses by 10 to 20%. At the second consultation, in about 2 to 4 weeks, consider increasing the dose of GLP-1 agonist. If the patient is having hypos, identify when they are occurring and reduce the relevant insulin dose by 10 to 20%. If BGLs are within target, reduce the total daily insulin dose by 5 to 10%. And if GLP-1 agonist is not tolerated, cease the medication. At the third and subsequent consultations, continue to up-titrate the dose of GLP-1 agonist. If BGLs are in target range, continue to reduce or wean off the insulin dose. If BGLs are still high, adjust the insulin dose accordingly. If not tolerated, return to the maximum tolerated dose of GLP-1 agonist. If ceasing GLP-1 agonist, start alternate therapy, such as increasing the insulin dose and restarting the DPP-4 inhibitor. For more information, we do have other health professional videos you may find useful: GLP-1 agonist, types of insulin, and what insulin should I choose for my patients.